Hi everyone. Today we are really fortunate to have Dr. Caroline Buckee among us to share about her thoughts and work on making data and model, like big data models and data for good better. Please allow me to give a brief introduction of our speaker. Dr. Buckee is a professor of epidemiology at Harvard T.H School of Public Health. Her work is focused on understanding the mechanism driving the spread of infectious diseases that impact the most vulnerable populations worldwide, particularly malaria. Before coming to Harvard, Dr. Buckee completes a DPhil, Doctor of Philosophy at the University of Oxford, and the Omidyar and Wellcome Trust Fellowships at St. Santa Fe Institute and the Kenya Medical Research Institute, respectively, where she analyzed malaria parasite, evolution, and epidemiology. Dr. Buckee's group uses a range of mathematical models, experimental and genomic data, and big data from mobile phones and satellites to understand how human pathogens spread and maybe control it. Please be reminded that there will be a 10 to 15 minutes Q&A session at the end. For those on Zoom, please type your questions in the chat box and we will bring them up to Dr. Buckee at the end. Without further ado, please take it over.
Thank you. Can everyone hear me? Yeah. Okay, so I gave this title a while ago. I don't know how relevant it is. I want to start by first of all acknowledging that all of the work that I've done is thanks to the graduate students and postdocs that have been in my lab. These are the former people. And so all the work that I'm going to talk today is really thanks to them. And as an outline, I thought I'd talk about the 7 stages of womanhood to illustrate my trajectory through my career from a bright young child who liked science and thought I wanted to help people. And then I'm like, I'll be a scientist. I know I'll work in global health. And then I got this job and then I had babies and now I'm like an old crone that's mainly just property. So I think I'm like about here in this trajectory. And so I want to order my talk basically chronologically to explain kind of how I got here. I came to Harvard in 2010. And that sort of is how the trajectory of the talk works. So first I'll talk about the role of modeling for malaria surveillance and how models are used at the moment. I'll transition to talk about mobility data more generally and the whole like data for good movement that I think is a justification for the title and some of the frustration I felt over the last few years. And then I'll end with back in malaria, thinking about data and models and other reasons that I'm grumpy. And everything that I want to talk about today is really about how we take data, how we analyze it in some way, and how we actually use it for translation. So we talk about translational research, and a lot of the time that concept comes from a sort of pharmacological background. So if you think about drug discovery, you work in a lab, you do clinical trials, and then somehow there's implementation. If you do global health, a lot of the problems here are to do with delivery, not discovery, right? And modeling often is trying to be translational. We're trying to have some impact in the real world. And I question whether a lot of the models that are being produced actually end up having translational impact and how we think about that. So I spend a lot of time thinking about this pipeline. And when I say models, I want to distinguish between 2 principal kinds of models. I'm not talking about statistical models mostly. When I say model, I'm talking about the dynamical model, which you're all familiar with, which I think of like this Heath Robinson machine for making pancakes, where there's some mechanisms that fit together. We can see explicitly what's connected to what. We know what the output is supposed to be, right? This is a sort of presumably nonlinear system. And so that's what I'm talking about when we're talking about models, which is quite different from literature on models for chronic and non-communicable diseases. And it's kind of the workhorse for what most of us do. And when we think about all the uses that we have for these kinds of dynamical models, I think they fall into different categories. One is to try to understand mechanisms. So this is a paper by Stephen Kissler, Jonathan Brad, and others here, thinking about, okay, in a general qualitative sense, what do we expect from the different assumptions in the trajectory, in this case of COVID-19, assuming different things about immunity or seasonality or infections, right? Maybe we want to estimate a parameter, estimate something important like age-specific mortality. Maybe we want to do a forecasting, which could be statistical, it could use an ensemble approach. And we've seen a lot of efforts here, especially coming out of UMass Amherst and now in the CDC, to bring together a bunch of models to make predictions in a very specific quantitative way. And then there's a whole class of modeling tools that are used for scenario planning. So this is like models for saying, what happens if we do this type of intervention in this setting? What can we expect in terms of the dynamics of the disease? Which different interventions should we combine for maximum impact? When can we reach particular targets and how can we do it? What's the optimal way to do that? And this has become something that is increasingly important and used for national programs at the national level in consultation with organizations like the Gates Foundation or the Global Fund. So Bruno Moonen at the Gates Foundation, for example, developed this framework with a bunch of other people thinking about using scenario planning models as a way to actually think about whether things like malaria elimination are feasible, right? So we might have some sense of operational feasibility. We're going to use models to assess the technical feasibility and possibly the timelines on which those goals should be reached, and then work with country programs to think about financial feasibility, and then supported by international organizations like the Global Fund or USAID or whoever else, think about budget allocations on a global scale for how we're going to reach those national targets, with the country programs then on the hook for trying to implement what is recommended. Modeling in this way is also used for a bunch of these types of exercises to think about what's possible, to think about how it could work, to think about the impacts of climate change and what that might do to transmission and so on. And these are the models that I want to focus on today. One of the ways that these models can be used on a national level often comes down to decision-making about resource allocation. And for those models, the key components here are often case counts, how many people have the infection, and denominators. So what is the population at risk, right? And case counts and denominators are both data sets that are often highly uncertain and difficult to get. But we might want to use models to know things like what's coming next, where will the disease go, and so forth, with the explicit intention of guiding resource allocation. So this is a map of Cambodia showing malaria parasite incidence. I can't know what year is it, 2011. And so the country might want to know, okay, so we've got lots of infections on the border. We've got this other area that seems to have transmission. What's going on here? Are these imported or is this not imported? Can we use models to help guide some of those decisions? And of course, maps like this have a very long history all the way back to our very favorite guy, John Snow, where essentially we're trying to map what's happening with our population and then make sensible decisions about interventions. The way that we understand who's affected by the disease and what's happening with it generally comes from reports from clinics and hospitals. So I think this is actually Bangladesh, but the idea is that you have clinics from all over the country. They're reporting how many cases they have, how many people they've tested, and so on. And then the country program makes a decision about how to allocate resources. For malaria, we have a range of different types of interventions. We may have insecticide-treated nets. We may want to spray. We want to make sure people have access to treatment. We have larval control, environmental changes, these kinds of things. We want to know where to put those things. And one of the reasons that this is difficult, and something that I've spent most of my career trying to work on, is the fact that people move around and you need to put these interventions in different places. So if you imagine a scenario here where this person is actually contracting malaria, so being bitten by an infectious mosquito in the forest when they go to work, and then they come home, and then at some point they seek treatment. The incubation period for malaria is about 2 weeks. That's when you first start to feel sick. Maybe you go to the clinic then, maybe you don't. But there can be quite a long time and distance between where you actually were infected and where you show up in the clinic. And the reason that that matters for the control program is that you're trying to do transmission reduction and vector control where transmission is happening. You're trying to make sure you get treatment to the clinics where you need to have diagnostics available and so on, right? And then you have people's homes, you're trying to protect them with bed nets and indoor residual spraying. There's education campaigns, and those things might be separate in space. And you might need different types of, you might need to think about access differently in the different locations. And in fact, mobility and migration, not only is it rising in a broad sense, and we know this in the context of climate change and climate migration, so we're seeing larger internal displacement as well as refugee migration, but there's also the sort of everyday, the labor migration movement, seasonal movement, normal behavior that's taking place all the time. And there's this fundamental problem, which is that all this travel is going on, but the only places that we're getting data from happen at the very end of a chain of lots of complicated social and economic decision making. So in a lot of the places where I work, labor migration from mining or junk cultivation or other things in the forest happen quite far away from where there are clinics. And that's a problem. So these are pictures from Guyana and from Colombia where I work. And all that's being shown here is the location of infection. And the way that we know that is that they asked the malaria patient the question, where were you 2 weeks before your symptoms started? Which of course has many uncertainties associated with that question. I can tell you where I was 2 weeks ago. And then where the diagnosis was made, right? So depending on the geography, the social dynamics of that population, the economic drivers and so on, where the cases are being reported from may not be related to where transmission is actually happening. And it varies between places. So you can't necessarily guess or just make a simple mapping approximation. So we have all of this complex social drivers, as well as environmental changes underlying transmission. We have some cross-border movement here on the Venezuelan border and sporadic patchy transmission dynamics. What happens is those cases are reported up and then aggregated on some spatial scale. And as modelers, what we may do to try and help the country with scenario planning is to put this into a meta-population framework, right? Where we assume kind of islands of populations, we model transmission dynamics within each connected population, and then we try and think about how we would estimate migration rates between these different islands, right? And it's still the case that in most places, the only data on this is from travel surveys. Census data tends to be on a much too long timescale for transmission, and there are other problems. So something like 15 years ago, we started to work on thinking about whether we could use mobile phone data to do this in a sort of more rigorous way. So obviously, this is smartphone ownership, correlates with income, GDP in this case. So penetration of smartphones is reaching 100% in high income settings, but it's very high even in low and middle income settings as well. And that's smartphones, so dumb phones, it's even higher, right? So we now have a distributed data set continuously being generated on the location of millions of individuals, which I'm sure you all know. So the mobile phones, there are different types of data being generated by your phone. SIM cards from a dumb phone, for example, they ping towers whenever they make a call or a text or anything like that. So if you know the cell tower that phone is pinging, you know where it is, you have an approximate location, you can aggregate that up and come up with sort of estimates of flow between different locations. For smartphones, if you're using Google or Facebook or something like this, it's more of a GPS trace that has different types of uncertainties and so on. But there's now a ton of data out there. So we started doing this ages ago with one of my first graduate students, Amy, who is now professor at Hopkins, where we thought, okay, let's combine data layers on where everybody is. This is where all the towers are. This is the malaria prevalence estimated from those case reports, as I showed you. Let's put it all together, and then let's make a metapopulation model. Okay, and then you can say, well, it looks like there's a lot of infections coming from the Ugandan border, and they end up in the highlands and in Nairobi. And so that's useful because you can decide whether you want to try and impact a high burden, high transmission setting with vector control, or mop up imported cases in low transmission settings, right? So for a long time, until the pandemic, basically, this process of getting access to data was incredibly difficult. And I drew this when I was working with Telenor, a Norwegian operator that had business units in South and Southeast Asia, to try to identify where the problems were. And this map shows all the things that we had to do, right? Here's us up here in academia. We had to have a lot of conversations with the Ministry of Health. We needed regulatory approval. We needed, sometimes this was very complicated. We had to have the operator sign on, all kinds of problems with getting access, with the algorithms that we were going to use, and so on. So extremely time consuming, contingent on particular individuals being willing to do this, usually one time only, retrospective data, complicated. Nevertheless, we were able to show that this could be useful. So this is data from Bangladesh. Aisha Mahmood did this work, showing movement out of Dhaka during the Eid holiday. So we know holiday travel is very important for the spread of infection. And here you're looking at a heat map showing travel out of the capital. Dhaka is here in the center. You see this weekly frequency of people leaving the city for the weekend and coming back. During Eid, these are the Eid holidays. You can see, these are all of the districts ranked by their distance from Dhaka. So this is close and this is far away. And you can see that during Eid, people go to all parts of the country. So sort of doesn't matter how far away it is, people are going to visit family for the holiday. And in 2017, there was a big chikungunya outbreak, and we were able to show that you could use this data to make predictions about where to look for new cases that pop up. So we've done a bunch of papers looking at this on different spatial scales for dengue, for malaria, for rubella, showing that these broad scale patterns of mobility do a better job of predicting and making sense of infectious disease transmission dynamics compared to the traditional way of doing it, which was a gravity model. And I'm happy to kind of go into that later, but a gravity model is kind of the standard way we thought about it before, but it wasn't really parameterized, especially in low income settings. So then the worst public health crisis for infectious disease epidemiology hit in 2020. And I think it's really easy to forget how much of a disaster this was and how many people died and continue to die. And this really changed a lot of things about public health, infectious disease modeling, and I'll come back to that, what's happened since COVID-19. Oh, you can't see any lines. Well, believe me when I say that before and after lockdown, there was massive changes in mobility. Obviously, every country in the world practically locked down, and suddenly everybody needed to know about mobility and behavior and what was happening. Were people following the lockdown? You know, were people leaving the cities and so on? And in response, having spent years on negotiating data access agreements and all this type of thing, overnight, practically, all of these corporate entities started putting out these mobility reports and putting out data that they have. So most of these companies collect this data as a matter of course, right? They use them for churn analytics and various other things. So suddenly we had all of this stuff. Apple, Descartes Labs, Cubic, all these people, including Facebook, who had actually started doing this with disaster maps a few years before. It became apparent that this kind of data was useful. So what we noticed, and this was building on all of the methodological work we've done in how you analyze this data, companies have all this data, policymakers wanted to make data-driven decisions, but they had no idea how to use all of this. The main thing was this data is not collected for the purposes of public health, and it's on the wrong spatial scale and the wrong temporal scale. And the companies putting it out did not have expertise in public health. And even if they did, they weren't working with specific decision makers. So when you spoke to an actual person responsible for Miami, who was supposed to be integrating this data, they were like, I don't see how this can help me decide where to put my mobile clinics, right? And I think we all had experience of that. And so again, the data is there. The methods aren't really in good enough shape to integrate it with specific decision-making so that we can actually translate it to impact. There are loads and loads of studies using this, that's fine, but is it actually making a difference for people's decision-making? So I don't know if all of you remember 2020, it was a little chaotic. We all kind of did the thing that we thought that we could be helpful doing. And so together with Satya Balsari, who's an emergency medicine physician, Andrew Schroeder, who works for Direct Relief, and my then graduate student, Nishant Kishore, we set up this thing called the COVID-19 Mobility Data Network. And the idea was that we get a bunch of our friends, basically, in the IDF world, build out a pipeline for taking all this stuff, and then working with specific policymakers around the country and around the world to make maps for them relevant for the questions that they had. So we were producing daily situation reports for Massachusetts, for Boston, for tons of cities around the country. And every day we would send them a report and we would say, this is what's happening in your place. This is the uncertainty. This is how it's relevant for the question that you asked us last week. So we had this like iterative engagement with them so that they could learn what these things mean. And we tried really hard to assess whether they were using it or how they were using it in their decision making. And so many of them said to us, I don't know, but I need to see it. So we literally have people on the phone saying, you didn't send the report today. And it's like, well, sorry, it's not clear to us. Are you really, do you need it? But they claim they used it a lot. So we have a qualitative study on that separate. And that led into the formation of Crisis Ready, which you can go to the website and have a look at our annual report if you'd like. But the idea here is that translation requires distributed networks of technical people who understand data and can translate it in specific policy contexts. You can't make a dashboard for the world and be like, this is helpful. It's not helpful unless it's tailored to a specific decision that somebody has to make. And I think that there was so much, during COVID, that happened so much, right? Well-meaning people who were very technical, who would put out things, and there was no iterative engagement with the end user, and so it just wasn't used. And I think one of our friends made a dashboard of dashboards at some point. But so in terms of preparedness, pandemic preparedness or preparedness for any other kind of crisis, we have to have all of our ducks in a row for data, because data doesn't just automatically exist when you need it. Data sharing agreements, MOUs, pipelines, servers, all of that has to be set up in advance. You need to know what you're going to do with it specifically before something bad happens, because when something bad happens, the decision maker doesn't have any time to work with you on exactly the spatial scale they need and so on. And then you have to have somebody who's going to be there and actually work with them to get this operational. So I feel like in academia, we try and contribute to this bit, right, to the methods piece. And there is a lot of really important stuff to be done there. And one of the takeaways from maybe the first part of the talk is that you can't uncritically use this data and assume it's fine. It's not fine. We need to do a lot of work. So COVID-19, the availability of all these new data sets allowed us for the first time to compare next to each other a bunch of different mobility data sets. So we did a ton of work. Nishant led a lot of this, actually. A lot of work just trying to figure out methodologically whether, like, how biased things are, how skewed it is socially, all of those questions. So this is Colorado, for example, and this is Canberra used ad tech data. Be very wary of ad tech data, which is SafeGraph. Be very wary of SafeGraph. Here's Facebook. So there's urban-rural differences, very pronounced. There's clearly social differences. It skews like young adult and wealthier. This is data from smartphones generally, and you can see that coverage is generally quite low. It doesn't mean it's not useful for some things, it's just that it's important to be aware of these biases. And we've been trying to make like standard frameworks for both analysis, reporting, and privacy. So there's been a lot of the regulatory landscape for this data is based in like the 14th Amendment or some crazy thing. And so there are organized like companies now that are using this data in a responsible way. And during COVID-19, we had several police departments reach out to us to ask for information during some of the protests, the George Floyd protests. So I think we have to be very clear about what we're using things for, why, and how privacy is going to be preserved. In Bangladesh, we're able, because we have this long history of working in Bangladesh with the operators, we had set up a team. There was a team there that was able to do this type of analysis. And when COVID-19 happened, Bangladesh mandated that the operators all contributed their data to this organization called A2I. So we were able to work with them to look and see, okay, how biased are these things? Like, can we use them? Can we put them into models? And this is work by Taylor Chin, who graduated last year. And so we had 3 operators and Facebook data from Bangladesh for the same time period. And again, operator data depends on where their towers are, right? So your estimates resolution depends on the density of the cell towers and where they are, obviously. And what happens in countries with multiple operators is that they often like end up stratifying or taking a niche of the country, either geographically or socially. So you can see even the top routes of travel are different. The Facebook data was largely confined to Dhaka, to the capital, where it's sort of urban and wealthier. And so what Taylor did was she just simulated an epidemic on these different networks to see, like, are we going to get this really wrong if we just start uncritically putting this stuff in? And I think the answer is yes. We have to be careful. So this is a standard gravity model result. We seeded the epidemic in multiple different places. Here you have, so the heat map reflects the time to introduction. So like, when are there going to be 10 cases in that place? On what time scale? And the epidemic dynamics differ by which operator you're using. And if you're using smartphone-based data, you're not going to get coverage in a lot of places. So some of these biases, again, I don't think that means we shouldn't use them. I think it means that we have to, there's a lot of academic work to do on methods, and we have to be very clear when we communicate uncertainty to anyone that's using this for actual decision-making. So in this pipeline, right, the way that I've set it up, we have data in industry, and I think this extends beyond mobile data. Obviously, there's lots of data now beyond traditional surveillance and epidemiological data that we may want to integrate into our translational pipelines. Climate data, satellite data, you name it. And at the moment, we've been working, thinking that, okay, well, we need to figure out the methods, and then maybe we can work with decision makers to help them make this better. And once we have that figured out, you don't really need us anymore, hopefully, right? So in Latin America, for example, this is in Central America, we're working on putting together some of the structural regulatory data sharing agreements necessary for the mobile network operators to automatically do some analysis and share it with the disaster response agencies across the Central American region. Just in the context of extreme weather events, looking at displacement, right? So for that, I think that we have robust pipelines now. We can do it. We can help them figure out how to do this analysis. Okay, maybe. So the things that seem to have worked, the experience with the mobility data network and Crisis Ready, as I've kind of got more towards implementation, is that it works when you show data with minimal analysis. because you've already had this conversation and you understand what the data is and you can be explicit about uncertainty with that data set. It's not a complicated model on top of an uncertain data set. And then critically, you have to understand the decision that will be changed from your model or data output, right? If no decision will be changed by the thing that you produce, then what's the point? It doesn't, who cares, right? Then you're just doing it for fun or something. So here, for example, in these situation reports, which if you go on the website, you can see tons of them because we respond to as many disasters as we can. We've broken it down into like mapping where the disaster is. This might be a fire perimeter. It might be a flood extent. The mobility patterns of the places, the counties affected. This is in the context of the US. And then something about the vulnerability of the underlying population. So how many people in that place do we expect to have electricity-dependent medical needs? How many are vulnerable in other ways? And then we work with the Red Cross or whoever else to figure out very basic things like where should we put the tents and so on. Okay, so I'm going to transition back to infectious disease now, because I don't know whether it's just like generally getting old and jaded, but I think like this mobile phone data that's being uncritically put into models, epidemiological surveillance data, I think is often also put uncritically into large, complicated models. And in many settings, the surveillance data itself is very uncertain. So we have transmission, true transmission, depending on all kinds of things to do with your health system, your treatment seating, all the things that I showed at the beginning. You have some confirmed cases with reporting delays, hospitalizations and deaths. So this is region 9 in Guyana, right? You have infections occurring. Some of them are diagnosed, some of them are not. It's a very complicated data landscape. And in the words of the great sage, Donald Trump, we have this fundamental surveillance problem, right? Where if you don't know about it, you don't have cases there. And this surveillance problem causes all kinds of problems, I think. Politically, there are incentives politically for countries not to report cases. There are all kinds of incentives at the local level too to do with reporting. And so the data itself has to be understood for its own sake. So I work in Guyana a lot, as many of you know. Here is a map showing an aggregated case count of malaria. It's restricted to this hinterland region, which is highly unpopulated. It's Amazon forest. It's mostly indigenous communities live here, and it's dominated by artisanal gold mining. So we have labor migrants who travel broadly throughout the country to conduct mining in small teams from 3 to 30, depending on the type of mine. And when they have some gold, they'll go and sell it. They'll go back to Georgetown. So even though Georgetown in the capital, which is up here, has no endemic transmission, about a quarter of malaria cases are diagnosed in the capital because there's so much migration around the country. And the gold mining, deforestation, malaria dynamic is so pronounced that you have a very close correlation between the international gold price and the number of malaria cases in the country. So here's the correlation with the 2-month lag for the gold price and the number of malaria cases. And this gets even tighter if you just break it down to men between the ages of 15 and 50, which is basically a proxy for your gold mining community. So we have cases in hard to reach populations, and miners generally prefer not to seek treatment within the health system. In Guyana, artisanal mining is legal, so it's not like in other countries in the region where it's not legal, but still, there is some illegal activity, and also they just tend to like to be deep in the mines and not come out, and they often go and get self-medicate, and there's lots of problems. So there's lots of reasons that their data isn't in the health system at all, or it's delayed. So this is one of the malaria daily case registers from Region 1. This is the map I showed you from before for Region 1. It's on the Venezuelan border. This is the border with Venezuela. There's a lot of migration. There's a lot of mining activity. And people come out of the mines if they get really sick, but if they're not super sick, they prefer to stay. Partly because they often don't get paid unless they stay for their full 3 or 4 weeks or whatever it is. It's not digitized because this is thick forest. Travel is very hard. It's often by boat. And so we have daily case registers, and they have to make their way on a thumb drive and a hard copy by boat and by plane to the capital. So what we see is pronounced reporting delays. Tiggy just graduated this week. Her work, she looked at reporting delays in Guyana. And so you can see here, this is Region 1, this is that region. Only less than a quarter of cases that happen in a month are reported by the end of that month because of this really intense difficulty of just getting the information from the regions here to the central office. And that's true for all of the endemic regions. Region 4 is the capital, therefore there's less of a delay, so most of the cases are reported by the end of the month. And so this is a problem. When we were visiting, when I took this picture, 3 people came into the clinic. They traveled by canoe from Venezuela to the clinic. The youngest boy, he was 14, he had Vivax malaria. He'd had it for at least 2 weeks. They'd come from a mine in Venezuela where there were no treatment available. So they knew that there was a clinic that had treatment. They paddled all the way. He'd got treatment. Whether that case goes into the central office report as being imported from Venezuela, maybe it did, maybe it didn't even make it to the central office. So there are some really fundamental problems with data from some of these regions that we need to take into account. And my issue is that what happens is we have this very complex situation. It gets aggregated onto a regional level, then it gets sent to PAHO that produces an annual report about the number of cases or the incidence of cases based on an old census, by the way, into a regional report on the number, and then that somehow gets into these giant models. This is actually a prediction about the burden of malaria in 2050 under climate change. The layers of uncertainty within this final global model that is used, that gets into Nature and is widely quoted and is used as a way to justify the feasibility of elimination. When you take it back to your individual country program that's trying to solve their malaria problem, I think there's a sort of a problem here, right? Nevertheless, okay, so we want to help Guyana think about elimination. The Global Fund, which supports a lot of Guyana's malaria program, they commissioned an investment case using a mathematical model to think about scenario planning for malaria elimination in this context. So they had a meta-population similar to the ones that we often use. They didn't have any data on mobility, so there was sort of general gravity model assumptions used based on census data that was probably outdated. And here there is modeled transmission, but we don't really know about the mosquito vector. So we just use vector information from somewhere else, I think in this case, Southeast Asia. We're not really sure about how to parameterize treatment seeking, but that's included because they wanted to include all kinds of scenarios, right? So here's the model, and I'm not trying to pick on a particular model. The authors of this model were very explicit about the uncertainties and wrote a lot about how there were many uncertain parameters, but that ended up in an appendix. So here, many parameters, often not relevant for that setting. It's a very difficult problem, right? I mean, here you can see that they estimated from data the maximum populations of mosquitoes. I don't know how they did that. That seems very hard to me. And what comes out is a scenario plan for Guyana that says, don't worry, it looks like you'll be able to do a lot if you just do X, Y, Z. And some of those things were things like increased treatment seeking from 24% to 37%. Okay, so these are complicated social parameters that are largely unmeasured. And the main drivers like migration for mining, you can't really include them. So my issue here is that this is being used to impose targets on a national program contingent on funding from the person that funded this, from the Global Fund, right? And then the country program is told that they're failing if they're not reaching particular targets. Never mind that 2020, obviously, everything got disrupted from COVID-19. So it's not that the model is wrong per se, it's that this doesn't seem like a sensible use of a scenario planning tool. And I worry that our models are becoming more and more and more and more complicated. And even when students come into a modeling group, they're often just given one part of the model to work on, or they just run a model that has been going for ages, one of these very complicated models, and they don't have a chance to figure out how uncertain things are. And maybe they can't even do that. And I worry that we're going from these like beautiful Heath Robinson machines into the realm of just making video games that look lovely, but I don't know if they're useful. And so in his paper, Bob May, I encourage you all to read this paper. He writes, it makes no sense to convey a beguiling sense of reality with irrelevant detail when other equally important factors can only be guessed at. And I worry that this is what we're doing. And so if you haven't seen Is It Cake? A bunch of cake experts look at some things that may or may not be cake. And then you can't tell it's cake till you cut into it, which my children and I love. But the point is that, like, I think it's very important that we ask ourselves, who is this model for? What's it being used for? And is it cake? And so when I was in the middle of my ongoing existential crisis, I think that there's some important things, right? Of course, we have to be funded. We want to be in this intersection of like interesting for us, but important and ultimately, impactful. And I worry that we have this hierarchy where math is clever, social science somehow falls further down on the hierarchy. And this is one of my favorite tweets of all time. I think there's this kind of hierarchical sense that the more mathy things are, the cleverer they are. And it's just not true, right? And I think some of these models that people put out have this authority of the inscrutable, where the people who are supposed to be implementing something based on them can't interrogate them properly in a way that you would want them to be able to. Okay, so I'm just about to finish. So first of all, this woodcut is the first known, this is a German woodcut about throwing the baby out with the bathwater. I'm not trying to say that models don't have a use in scenario planning or in our field or in public health. And this is a painting of the death of Marat. So Charlotte Corday was a French revolutionary who felt that the Jacobins were getting too extreme and radical, so she murdered him in his bath. What a hero. But so I feel like I want to be clear that I'm not saying that there should not be models integrated in public health decision making. I think we have to be very clear what we're doing and why. And instead of proliferating tons and tons and tons of very complicated models and then tying national programs to those outcomes, we should be, I think, aiming more for a distributed network, kind of like how we're developing crisis ready, where we have meaningful iterative engagement with local decision makers, and use potentially simpler models that are much more transparent and are helping make decisions that are meaningful in that context. And of course, that goes against some of the incentives we have in academia, which is to publish big things on, pictures of the world that are beautiful, and in high impact journals. But I think if we actually want to do translational work, we have to move more in this direction. So I'm happy to debate, and thank you.